السلام عليكم ورحمة الله وبركاته، الصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. نكمل فيديوهاتنا في الموضوع الكدني ترانسبلانت بيزك كلينيكال بيرلز. اليوم هنتكلم عن الاميونو سبريشن. طبعا انا مش هتكلم عنها بالتفصيل، ده مجرد مقدمة، وبعد كده ان شاء الله كل الموضوع ديت بالتفصيل في الحتة الكلينيكال فقط لا غير يعني. اميونو سبريشن، الايم بتاع الاميونو سبريشن عموما في الكدني ترانسبلانت تو just prevent T cell activation, lead to the T cell activation will end by either rejection, either T cell or whatever antibody mediated rejection. عندنا ال B cells والplasma cells والeosinophils, other immune system cells can also play a role in immune response. Immunosuppression typically include induction therapy وهنتكلم عنه بالتفصيل، والمينتنس ثيرابي. وزي ما احنا عارفين عندنا 3 models or 3 signals mood need to be activated to or need to be uh, alarmed to activate the Z cell to start attacking the donor kidney. We have signal 1, signal 2, and signal 3 all together should be activated to make your T cell activating to release cytokines and start attacking the foreign body is the donor kidney inside the recipient body. We have signal 1, this antigen specific from the donor antigen to the T cell receptor CD4 on and the major histocompatibility an antigen presenting cell. This also need co-stimulatory signal from antigen non-specific for signal 2, and this will end by lead to interleukin 2 production. And this all together will activate signal 3 for interleukin 2 and CD25, activate mammalian target of rapamycin emitters, and this will end by cell proliferation and activation. And as you can see in this diagram, we'll explain this the 3 models here, signal 1, signal 2, and signal 3. The antigen presenting cell will attach here to CD3 and the T cell receptor, major histocompatibility, and need co-stimulation also from signal 2 on CD28. And all this will end by just activation like calcium here. This will end as a cofactor for activation calcium urine and the calcium dephosphorylate nuclear factor activating T cells. And this will end by releasing more cytokines to stimulate the signal 2, to stimulate signal 1, and also to release interleukin 2. And if and by interleukin 2 and by just immature mammalian target of rapamycin activation, cell proliferation, and more T cell proliferation to more attack of the donor kidneys. Once the kidney inserted or transplanted inside the recipient, this T cell start to be attack the donor kidney, and not only this one cell attack, this will also activate more proliferation of this T cell to get more or collecting more, aggregate more T cell to attack the kidney transplant donor inside the body of the recipient. And we have a lot of medication working on every different sites or different recipient here. We'll come to discuss all this on immunosuppression in details videos in the future. And this is another diagram how this antigen presenting cell from the donor kidney to attach to the T cell receptors activating calcineurin and dephosphorylate this nuclear factor activating T cell will end by release more cytokines, interleukin 2, it's coming in to stimulate emitters and more cell proliferation to attack this donor kidney inside the body of the recipient. And timeline of immunosuppression as regard 1 year survival and rejection rate is too much improved at the moment. Since 2005 and more now 2025 we are more have a better survival with after 1 year and lower rejection rate with improvement immunosuppression from 1960s and 70s and 80s, they started by prednisone and radiation and methyl mercaptopurines and azathioprine, and different age 80s they started cyclosporin, and here now we are dealing just now with tacrolimus, either by the main CNI used now at moment, tacrolimus by different types, either Prograf, short-acting twice daily, or long-acting, either Advagraph or Inversus, and we'll come to explain what is caveat or what is the aim of using each one in comparison by others. And we have mycophenolate mofetil and mycophenolate sodium, this MMF, and we're using prednisone. This is the three main maintenance immunosuppression, and we have two main induction therapies: thymoglobulin, rapid ATG, and we have basiliximab, and this interleukin 2 inhibitors, and we'll come to explain all this in the transplant immunosuppression lecture in future. And this also the timelines to be clear for each one. It started 1950s radiation. They started radiation, steroids, azathioprine, and with the time now we are mentioned what medication we just using now, just tacrolimus by different trade names and different half-life, and mycophenolate or MMF, mycophenolate mofetil or mycophenolate sodium, and we have prednisone. Plus two induction, either ATG or basiliximab. This is only used now in Canada, at least, in the three hospitals I worked in. And they mention type of immunosuppressive or antibody induction therapy. What is the induction therapy? We have two induction therapy, as I mentioned. We have polyclonal, a specific anti-lymphocyte or lymphocyte depleting agent, a relatively potent and potentially toxic. This is rapid ATG or thymoglobulin. This polyclonal we are using for highly sensitized patient or high risk for rejection. And the second one, interleukin 2 receptor, non-lymphocyte depleting, just only work on active T cells, well tolerated, and little bit less side effect in comparison by thymoglobulin is basiliximab. Induction therapy depend on the high risk and the low risk according to the risk for your recipient. Is low risk patient like zero HLA mismatch, live donor. All live donor should receive basiliximab and some senicity, and low banner reactive CPRA, 0% CPRA. This will make you more assurance, more comfortable to use basiliximab. Absence of donor-specific antibody and blood group compatibility, immediate graft function, short cold ischemia time, and first transplant. All this will just make you a little bit comfortable. Shows I will use basiliximab, and I am not afraid from rejection as a side effect post-transplant. Also, high-risk patient, increased number of HLA mismatch between class 1, class 2, all mini mismatches, and younger recipient and older donor age, African American ethnicities is high patient, high risk for rejection, high panel CPRA, panel reactive antibody, presence of donor specific antibody, blood group incompatibility, and delayed onset of graft function, long cold ischemia time, delayed graft function, and retransplant, second transplant, highly sensitized, better to use ATG or thymoglobulin. ان كلينيكال على يعني ان كلينيكال اميون سبريشن، الحاجات اللي فعلا بتستخدم ايضا زي ما قلنا اندكشن باي ايذر انترليوكين 2 ريسبتور انتاجونست، ده اللي هو البازيليكسماب، انتي ثايموجلوبولين اي تي جي، ده اللي هو الاي تي جي اللي احنا عارفينه من الرابت. And goal of this maintenance just to reduce the risk of acute rejection from this induction therapy to reduce the risk of acute rejection. Maintenance, as I mentioned, for use cyclosporin, CNI, tacrolimus, and antimetabolite MMF or myfortic, and then the steroid. This is a goal to reduce the risk of acute and chronic rejection. This is the aim for this maintenance and induction therapy. most common regimen today, thymoglobulin and or basiliximab as induction therapy and maintenance, tacrolimus, cyclosporin, mycophenolate, prednisone. But most now just tacrolimus, mycophenolate or mycophenolate mofetil or sodium and prednisone. طبعا بتختلف من center لcenter, program to program, patient to patient also according to the risk of the your recipient. سي 9 كونفرشن انا في اللينك ان شاء الله، فكروني ابعت لكم اللينك ازاي تستخدم فيه لايك حاجه زي لينك كده تفتحه تعمل منه ازاي تعمل كونفرشن من الاسترويد للهيدروكورتيزون مثلا، او من السايكلوسبورين ازاي تحوله من اورال اي في، او من التاكروليماس للسايكلوسبورين. هنا العيان لو انت مثلا ماشي على اي في سايكلوسبورين دوز كونفرشن، لو 3 مللي جرام اورال بتدي له 1 اونلي مللي جرام اي في. تاكروليماس لو بياخد 1 مللي جرام بتدي له سايكلوسبورين 75 مللي جرام، على حسب ما هنحول لكم المعادله دي طبعا من الاوت تو ديت. طبعا كونفرشن العيان بياخد، لو معظم العيانين لما بيبقى acute illness or sickness or ICU need to confirm his maintenance prednisone to hydrocortisone, but usually we are not giving 1 to 20 for prednisone to hydrocortisone. Just we are giving, for example, just we are giving just 50 milligram every 8 hours or 6 hours, or 100 milligram every 8 hours for 2-3 days until your patient is stabilized and they can take oral. And I will send if you use this link for easy conversion in immunosuppression to others, especially in critical care patient. Post-transplant prophylaxis, we are giving just oral trash, this mouse swish by nystatin, 500,000 to 100,000, just unit per oral swish QID. Don't swallow, just swish and spill. For pneumocystis, GRFCI pneumonia, just for Septra or Dapsone or Pentamidine, this depend, or Rotovacon, this depend on the allergy for Septra or no, but Dapsone you should do J6PD deficiency before you starting. And CMV prophylaxis valgan cyclovir, this depend on CMV positive donor, negative recipient will give for 6 months. CMV negative donor, negative recipient, usually we are giving just a cyclovir, not valgan cyclovir for 3 months. All this according to the estimated GFR, the dose of all this medication, and all other patients just for 3 months, either CMV positive to positive or CMV negative donor positive recipient should give just 3 months valgan cyclovir. Again, CMV positive donor, negative recipient, 6 months valgan cyclovir. CMV negative donor, negative recipient, 3 months acyclovir. All other patients, just 3 months valgan cyclovir prophylaxis, and those adjusted according to the estimated GFR. We are giving PPI or H. Usually we prefer ranitidine, 150 twice daily, better than pantoprazole as a GI protection, because PPI, two problem now for pantoprazole, either leaking magnesium, hypomagnesemia from the tubules by PPI. The other side effect, interstitial inflammation, like acute interstitial nephritis, chronic interstitial nephritis, inflammation inside the kidney. We don't like this side effect, especially in recovering post-kidney transplant. It's better to start by ranitidine, and if the patient can tolerate, we can shift to pantoprazole if needed. Post-transplant antibiotics because of positive donor, either urine or blood. This depends on the donor history and the culture for deceased donor. Other immunosuppression medication used in transplant, we have rituximab for antibody-mediated rejection, IVIG for also antibody-mediated rejection, BK virus, CMV, and leflunomide in BK virus, bortezomib, antibody-mediated rejection, oclozumab, antibody-mediated rejection, tocilizumab, and tofacitinib. Already all this can be used in antibody-mediated rejection, but usually we're rare to use this medication, except intravenous immunoglobulin is commonly used with, and rituximab commonly used with Rituximab especially is recurrent focal segmental glomerulosclerosis. Some centers using for antibody-mediated rejection, also with bortezomib. And IVIG also used for BK virus, parvovirus, and CMV virus infection. ونكتفي بهذا القدر، وإن شاء الله نتكلم عن الإميونو سبريشن في محاضرات يعني مخصصة للإميونو سبريشن by details for each medication used and who's used now and who's not used and what is the clinical trick around each medication قريبا إن شاء الله. ونسألكم الدعاء بالتوفيق والسداد، والسلام عليكم ورحمة الله وبركاته، ونلقاكم بفيديو قريب بإذن الله. السلام عليكم.